and get started. So if the pandemic has taught us anything, it's that there is a value in being able to do things via telepresence. And this is kind of a new one for me. I've done some televideo presentations, but it's a little challenging because normally you get to see who's in the audience. You could see who's nodding, who's laughing, who's falling asleep, who's giving obscene gestures. And today I really not able to do that. So let me press forward anyway. So I'm a psychiatrist, addiction doc, and pain doc, been in Hawaii for about 25 years, mostly in Kona. Lived on Oahu for a couple years and did administrative psychiatry with the Department of Health. I've worked in just about every part of behavioral health. Inpatient is where I'm at now. I'm actually on a behavioral health unit in Kealakekua, South Kona, but I've done ACT level, assertive community treatment. I've done homeless shelters. I've done crisis shelters, outpatient therapy, at community mental health centers, and actually worked at homeless shelters providing behavioral health. Actually did a televideo link with a homeless shelter, gosh, maybe 15 years ago, before it all became so popular. I was one of the early proponents of using telehealth because the Big Island is so spread out, right? So I don't want to do that. Okay. Don't want to sign in. I just want to put this on. There's a slideshow view.
Hey, Mike, it's Jerry.
Yeah.
Do you want me to share your slideshow with mine?
I have it, and it'd probably be easier than me having to do the, advanced thing. So let me just share my screen here. Okay. We want this one and share it. All right, can you guys see that?
Perfect, thank you.
All right, I'm just going to put that on slideshow view. Since you've all seen how handsome I am, you don't have to look at me anymore. Uh-oh. There we go. Okay. So as I said, been doing a lot of areas within behavioral health. And to me personally, the most fascinating thing about us human beings is our behavior. Why do we behave the way we do, have the emotions we do, and think the way we do? And when I went to medical school, I was fascinated with that organ that creates our behavior, our emotions, and our thinking, the brain. And so when we approach any problem, especially a challenging problem like homelessness, we have to acknowledge that it's our brains that kind of predispose us to how we approach that problem. And so I'm sorry I haven't been able to see many of the other presentations, but most approaches to complex problems involve short-term solutions that are kind of agency-based. An agency will specialize in one particular thing, and they'll be pragmatic and practical, and they'll provide that thing. My interest is in looking at places where that fails and looking for longer-term solutions that require a system-wide approach. So my talk today is going to be focusing on more of a system-wide approach to the most challenging homeless patients and or persons, and I'm going to talk about why that is. So a few take-home points, take-home messages. If you're going to remember anything from this talk, it's a fancy word, anosognosia. So I wish I could write it out if I had a chalkboard, but it's from Greek words, a meaning without, gnosis as disease, and gnosis is knowledge. So this is when a person, because of a brain problem, a brain dysfunction, doesn't have knowledge of their own disease. And it's a well-established neurologic disability. And what I'm going to be talking about today is how this disability is one of the biggest problems we face when trying to address the problem of that subset of really challenged folks that wind up homeless, those with severe behavioral health problems that I'm going to describe as high impact disorders. And when we approach that problem, a lot of these agency-based approaches can help those that are willing and able, but for those that, for this reason of anosognosia, are not willing or able to either engage or persist in treatment or in housing, unfortunately, we all know what happens. They wind up incarcerated, or they wind up in an inpatient unit where I'm at today. And those are the most costly forms of containment, treatment, whatever we want to call it. And it puts public safety at the highest risk a lot of times, and we'll address that. So what is the solution? I'm going to talk about the solution being a system-wide, cooperative, coordinated approach that involves the stakeholders getting together and coming up with some creative solutions. But to do that, we got to start with the same kind of understanding of this condition of what I'm calling high impact disorders. And we're looking at the first slide now. High impact disorders of executive functioning neuropathology. What a mouthful, right? But it's, if you look at the acronym there, hidden, because it's a hidden disability. This anosognosia that I'm talking about, you can't see it. It's not like a broken leg or an abscess. It's in the brain. And that's the real tragic and challenging part of this disability, is because it isn't visible. And so to a lay person, to an untrained person, they'll look at someone who has this neuropathology and say, oh, they look fine. They're talking, they're walking, they're telling me what they want and what they don't want. They should be able to do what they want and what they don't want. And we're going to point out why that really doesn't work in their best interest. So when we approach any problem, we have to have some beginning as to what we should do. And as we're moving along the road towards a utopian society, we might face an obstacle like this in our path. And we'll say, well, what is that? How should we deal with it? Well, let's bring in some experts, right, to help us. And you've heard of the old analogy about the blind men and an elephant, where if a person is limited by their own particular aptitudes and biases based on their experience, they're going to approach the problem at whatever point they can access, right? So if you can see that slide, the one in the front is touching the tusks and he thinks the elephant is a spear, and the one that has the trunk thinks it's a snake, and the one that's got the ear thinks it's a fan, and the one on the side says it's a wall, etc. And each one of those is right, but the entirety of the problem isn't being met. And so we need a different approach to more complex problems. And the difficulty with complex problems is that they're difficult, right? And from evolutionary psychology, we've learned that anything that's difficult requires a lot of energy. It causes us distress. And so we tend to look for simple solutions. And that is just human nature. And the more burdened we are with other issues, we're going to look for simple solutions to complex problems. And now you can even see that they've got new gluten-free simple solutions. And so, of course, people are going to line up for it. So let's look at what is the problem. Well, persons suffering from serious mental illness, these are thought disorders like schizophrenia or bipolar, and or severe substance use disorders. In Hawaii, methamphetamine is our primary predominant, and as well as opioid. Opioid because it has higher overdose fatality rate, usually. However, methamphetamine is up and coming in more recent research in terms of overdose and fatalities. But these persons that have these serious behavioral health, which includes mental health and substance, We know that they're at increased risk for homelessness. They're at increased risk for medical illness and mortality. They're overrepresented in the criminal justice system, and they're high utilizers of acute health care due to lack of appropriate and adequate treatment. And we're going to talk about that in more detail. So the chronically homeless, you probably all know this, according to the Office of National Drug Control Policy, up to 30% of the homeless have serious mental illnesses. I believe it's quite a bit more because a lot of times there's difficulty in gathering the data and actually making the diagnoses, but at least 30% have a severe thought disorder. And then other research has shown that up to 66% have substance use disorders. And as we know, tragically, many have a combination of both. The chronically homeless, this is the Hawaii definition, have been homeless for more than 6 months and have mental health or physical health conditions. More about the chronic homeless in Hawaii. Hawaii is number 2 in the nation for homelessness. We were trumped by New York in 2020. The average life expectancy for Hawaii's homeless is 53, almost 30 years less than the general population. And as we're talking, they have higher rates of mental illness, addiction, PTSD, etc. They tend to be disproportionately Native Hawaiian. Chronically homeless individuals, highest Medicaid utilizers in the state. 3.61% of the Medicaid users consume 61% of the $2 million budget. These facts came from some research that was in a paper a couple years ago looking at this problem. And this is looking at it in terms of cost, dollar cost. And we're all aware of this, right? That these persons that are struggling with what I'm going to talk more about, this anosognosia, that is the disabling sign and symptom of these behavioral health disorders, are high cost to the state, as well as their high personal cost. Methamphetamine use in Hawaii in 2013, 61 of Hawaii's 120 drug-related deaths were associated with methamphetamine. This is a little bit old data, but new data is pretty consistent with that. And growing methamphetamine, you can see the costs related to this behavioral health problem with methamphetamine in Hawaii. Number 1 in the nation in terms of percentage of folks with treatment admissions for methamphetamine. And you can see in our workplace testing in our state, 410% greater than the national average. And just more on this slide about what we all know, that methamphetamine use in our state is tragic. The way that it taxes our criminal justice system, which taxes us all financially, as well as in terms of our feeling of public safety related to criminal activity. A little bit of data here from a study I did at Kona Hospital, where I'm sitting right now. We just looked, kind of a naturalistic study, at urine drug screens that were done on folks that came into our emergency department, and 34% were positive for methamphetamine. And these were only the folks that somehow had some issue that caused the ER doctor to even order a urine drug screen. Oftentimes, folks will come in with conditions and they don't get a urine drug screen. So I think it's an underestimate, but by that estimate, we in Kona, and probably representing similarly in Hawaii, 17 times the national rate of folks that wind up in the emergency department. I'm doing some newer data related to what has happened during COVID. You know, it seemed anecdotally to me that there were more folks presenting to the emergency department. The data that I have is only from 21, which seemed to be at about the same baseline. I don't have data from 2020 yet. If you're interested, you can reach out to me and I'll let you know when I get that data. So the problem affects a certain population of stakeholders, and each of the stakeholders has a little bit different agenda. We're all concerned about it, right? but public safety is concerned about the criminal behavior and how it taxes the citizen in terms of their feeling of safety in the community. The government, they're concerned on many levels, but predominantly the financial burden with both direct and indirect costs, as well as the public health burden. Business owners, they have, capitalistic interest, and the homeless folks wind up costing them money on their bottom line. So they want the folks that have struggles with these kind of conditions we're talking about away from their businesses. They don't want them in their backyard, right? They put them somewhere, put them in a shelter, put them in treatment, but don't put it near me. I don't want that element around my business. And then we have in red the civil rights issues, where there are civil rights organizations that feel that have promoted the idea that homelessness is a lifestyle choice. And it's very complicated, of course, and it gets down to the dynamic of autonomy versus beneficence, where it's an old philosophic problem, it's an ethical problem. We all, in a democratic society and a free society, we want to be autonomous, to be able to make our own choices. However, when there are times when a person is impaired, they're lacking capacity, we may need to act in beneficence, acting in their benefit. And this is where we get into the complicated issues around the kind of folks that I'll be talking about today. And in healthcare, those of us that work in the healthcare field dealing with these persons, we see that they have what's called treatment non-adherence, right? We can offer them the treatment, but they won't take it, or they don't seem to think they need it. So therein is the scope of the problem for the different stakeholders. The proposed solutions, well, we start with education. That's what we're doing here today. We're learning from each other about the problem. And the way I'm presenting it is this hidden disability. And it's a diminished capacity. So these persons that have the agnosignosia due to a thought disorder or severe substance use disorder, even if you offer them treatment, housing, resources, because of the agnosignosia, they are unlikely to avail themselves of that treatment. That's the tragic part, the main take-home message that I want folks that are here to hear. The second solution is reform. We need to change the way the law enforcement and criminal justice respond to folks that have these conditions, the high impact disorder that I'll talk about, and provide leveraged accommodations. So this is, we're accommodating for that disability, that agnosignosia. We're acting in beneficence for this person. We're providing extrinsic motivation for change and engagement. And thirdly, reallocation of funding streams from acute care, like mentioned, to community-based ongoing behavioral health treatment that's appropriate. And so it will involve some of those leveraged, extrinsically motivated kinds of solutions, which I'll define more in a minute. So let's get into this hidden. What is he talking about, hidden? So high impact disorder of executive functioning and neuropathology. So we'll unpack that now. High impact is a term that I borrowed from the chronic pain research because it's noted that a lot of folks have chronic pain in the United States, but there's a certain percentage that have a higher impact. And what that means is it's meant to be destigmatizing, rather than put some label on them that somehow makes them bad. This just points out the facts that they tend to have more severe symptoms. So for our behavioral health folks that have a homelessness problem, they tend to have more severe symptoms, more intense, more chronic. They have more notable and severe functional impairment, worse overall health. They have higher healthcare use. They often are homeless with many high impact disorders, and that's our focus today. And they have frequent criminal justice contacts. So a picture of who are these hidden folks is it's kind of at the crossroads between substance use disorders, mental illness, and importantly, we have to be careful about antisocial and sociopathic behavior, because there are some persons that don't have a severe mental health problem and have mostly antisocial and sociopathic behavior, and we have to be able to differentiate because they should be on a different track for their recovery. So what causes hidden? Here's a little quiz. I don't know if anybody's still in the audience or still paying attention, but if you want to play along, maybe you win a prize, maybe not. Choose the best answer. What causes this high impact disorder of executive functioning neuropathology? Well, it's genetic, it's nature, or it's a result of some adverse childhood events. That would be a nurture. Or it's C, the result of environmental, social, or cultural factors. Or D, they are caused by harmful substance exposure, some toxicity, or E, all of the above. Well, as those of you that take a number of tests know, if they give you one of those all of the above, it's probably going to be that one. And that probably is the most accurate from the research that I've done and the experts that I've listened to. All those factors are involved in this disability. Unfortunately, as I alluded to earlier, there are persons that don't have this education, and instead they tend to project their own worldview onto these homeless persons and say, well, they don't have any problems with nature, nurture, or environment, or alcohol or drugs. That's just their choice. They wind up in that wretched, unfortunate state because they choose to be psychotic, refuse treatment, use drugs. And, civil rights attorneys tend to promote the idea that this is a lifestyle choice. That guy sleeping there, that's his lifestyle choice. And I understand their position. They want to be sure that, psychiatrists aren't going to be wandering around the streets with nets and, putting people in vans just because they think they should do that. And we need to protect autonomy. But what we're going to talk about is how sometimes we get lost in that. And this is from a very influential article in 1993 that talks about how that pursuit of autonomy can wind up actually depriving a person of their liberty. And I think you guys can probably get copies of this slide to read this quote. It's very poignant in the way that it points out that predicament, but I won't read the whole thing out today. You can get a copy of it. E. Fuller Torrey, who was the physician who, was involved with the Surgeon General position a number of years ago, has pointed out how when it comes to the challenging folks with psychosis, that number 2 there, ignorance among general public regarding the lack of insight, awareness of their own illness, what a predominant role that plays in the difficulty with providing effective care. So even if we had all the resources we needed, we had all the housing, we had all the treatment centers we need, which we don't, acknowledged, even if we had all those, this agnosignosia would get in the way of the persons that suffer from this disability actually engaging in those. So a little bit more about it. It's a neuropathology. It's a fancy medical term for something's wrong with the nerves in the brain. The brain is our choice organ. So if you give a person, I'm going to give them a choice to choose to go into treatment. Well, if your choice organ is broken, it's like telling a person with broken legs, just walk up those stairs and right up at the top, you'll get everything you need. If you don't provide a ramp, you're really not helping that person out. So this is another picture that as your level of neurologic disability increases, your freedom of choice actually decreases. And that kind of makes sense, right? Because your choice organ isn't working. So what is the neuropathology that's in this high impact disorder of executive function? Well, as we kind of touched on, the causes include genetics, nurturing, environment, exposure to toxic substances. And in a medical model, it's that end organ, they call it, that is diseased or damaged by those factors. And as we talked about, it's the brain, right? There it is. There's our brain. And I like this kind of, they call it tripartite model, 3 different parts. Of course, the brain is much more complicated, and even studies that try to localize functions to different parts of the brain have their limits. But if we do this just for teaching purposes, we've got the frontal part of the brain where the higher level thinking is done, the inner deep part of the brain, the subcortex, the feeling part, and then the spinal cord as being in the upper parts of the spinal cord, the doer part of the brain. So let's take a look at each of those quickly, because they're involved in the neuropathology. The deficits in the thinker part of the brain, that prefrontal, involve that executive functioning. Now, what is that? Now, that's not wearing a tie or a fancy aloha shirt here. It means the front part of our brain is involved in planning, impulse control, judgment, that insight, which is that anosognosia, there it is spelled out, not knowing one is ill, attention, and working memory. If you just look at that list quickly, how much do you need those things working to be able to accept, engage, and sustain in any kind of treatment or any kind of housing? And the answer is obvious, right? You need a very high level of functioning for those to be able to stay in housing and stay in treatment. And if you don't have access to good impulse control, good judgment, good attention, good working memory, good planning, you're not going to make it. If there aren't accommodations, if there aren't helps added to that for you, you're not going to succeed. The second part of the brain is the feeler part, and that's, the inner parts. I put the fancy names there for those of you that are brain nerds like me. But basically, they're involved in emotional regulation, anxiety, depression, this dysphoria, agitation, or anger, which can get folks kicked out of treatment, get kicked out of housing, decreased sense of self, self-esteem. I don't deserve this. And so they leave. Finally, the doer part of the brain, the dorsal striatum and lower, can lead to a thing called abulia, another one of those fancy Latin Greek terms. And that can lead to passivity, reduced social interactions, reduced interest in usual recreational, vocational things, reduced spontaneous speech. And you can see there are the rest of those that are involved when that part of the brain is impaired. So again, how can we expect a person who can see the person suffering from that invisible, hidden disability to move over to the right side of the slide to the right choice? Yeah, we all know what the right choice is. Get into housing, get into treatment. Look, we're going to open it all up. Suppose we did have access to completely adequate housing and treatment. Well, we can see that there's a big gap, a big chasm filled that person with the hidden disability can't cross unless accommodations are made. And just to kind of hit home on the idea that it is a disability, we look at the ADA definition of a disability: physical or mental impairment that substantially limits a person in one or more of the major life activities. And this is what a person with hidden really does have. The Law Commission's definition of an incapacity, you can see there, it's when a person is unable to, because of some kind of a mental disability, understand relevant information. That's really understand it, really retain it, and then make a decision based on that information. And I do this kind of evaluation in the hospital in persons that have some kind of brain issue going on, and we ask them, what's wrong with you? And if they have a brain impairment, if they're lacking capacity, they'll tell me there's nothing wrong. No, I'm fine, I can leave the hospital. But I'll talk to their primary doctor and, oh no, they've got a horrendous infection, and if they don't get this IV antibiotics, they're going to die. The person tells me, no, they don't have an infection. And it's already been explained to them. They've gotten the information, but they haven't retained it. And so therefore, they're not able to make a decision for themselves. So what happens, as should happen in any compassionate, beneficent kind of situation, we decide for them that no, they don't get to leave the hospital because their brain isn't working for them. It's in fact working against them. So the NAMI guidelines also talks about what we should do about that is utilize involuntary commitment, court-ordered treatment for folks that can't provide for their own basic needs, or those that lack capacity, meaning those that, as a result of some behavioral health condition, are not able to understand or lack the judgment to make an informed decision about their need for treatment, care, or supervision. So that gets back to the point of what we're talking about today. Many times I have folks that come into the hospital that are homeless, and they have one of these kind of hidden disabilities, either from schizophrenia complicated by substance use or exacerbated by cannabis use, high concentration THC. And even when we offer them treatment, if we're able to go through the hoops and get them treatment, they'll reject it because they don't recognize they have a problem, or they won't stay on their medication. So this is why it's important to talk about this hidden disability today. And as we know, the ADA, the American Disabilities Act, requires that state and local governments give equal opportunity for folks to get all the healthcare and social services. And what that means is the state has an obligation to make reasonable modifications to practices and procedures. So how we know the devil's in the details, right? How do we make reasonable modifications? Well, as I was pointing out, as your level of neurologic disability increases, your freedom of choice goes down. So we have to make some accommodation for that person's impaired ability to choose. And this is what I'm promoting, and this is what the research tends to support as well, that you provide accommodations in that green arrow in terms of starting with extrinsic motivation. This means, I'll talk a little bit more about it in a minute, but that the motivation for change comes from outside the individual because they don't have it initially. But as you can see, as the level of neurologic disability decreases, they move into a point where they're choosing for themselves, ideally. And the yellow arrow, we talked about diminished capacity from the anosognosia. They don't understand it. As they improve, they recover capacity, ideally, and start making their own choices because their capacity to make those choices has improved. So the sources of motivation for extrinsic motivation, as I said, come from outside the individual. And this form of accommodation for existing disability enables them to then be in safe place, to be acting in a lawful way, and benefit from sustained housing opportunities. Now, here's where the crux of it is. This may involve a guardian, conservator, or payee to help them manage their finances and make medical decisions. And as I said, as they improve, we move towards autonomy and intrinsic, or I'm making my own decisions. So that's kind of in a nutshell what we'd want to do. One of the ways that we're trying to do this more and more in Hawaii is with assisted community treatment. Now, this has been recently updated. It continues to be refined because this is challenging. It's a challenging process because of that dynamic between autonomy on the civil rights side and beneficence on the side of folks that understand this disability. So it's recently been updated. I know, the Institute for Human Services, IHS, has been really a proponent of this and doing some groundbreaking work to have persons that have this disability have accommodations made for them using this assisted community treatment law, but it continues to be opposed by civil rights attorneys. Another technique we can use is called contingency management. This is proven in the research, where for those that do have enough frontal lobe functioning, executive functioning, you provide contingency management, which is you provide tangible incentives or reinforcements for positive behavior, such as staying abstinent from substance use or staying in treatment or maintaining engagement in housing. This has been shown to work. If we create and activate more of these kind of programs, I know there are some that exist, but the more we activate these programs, the more success we'll have. Finally, here, it requires a coordinated working relationship between stakeholders. That is the person with hidden, the family, social, cultural, spiritual groups, the medical behavioral healthcare providers, social service agencies, entitlement agencies, state and local governments, public safety, and the judiciary. So it's quite an undertaking to get everybody to cooperate and coordinate. But for a big systems-wide approach, that's what we're going to need. Here's some more granular things. We need revisions to and continue to revise Hawaii Revised Statute 334 for ACT, guardianship and conservator. In terms of the criminal court, I need to update this slide because we now have Act 26 as opposed to Act 53, which provides a route to try to avoid criminalizing minor offenses, but the other 704 statutes should continue to be revised and updated and utilize extrinsic sources of motivation for folks that have the hidden disability. Supervised release programs, diversion programs, going home. There's a lot of great efforts being made. And as long as we're all educated on this hidden disability, that can help guide us in the right direction. Final summary slide, the accommodations. It'd be helpful to create a behavioral health court, and the merging of the drug courts with the mental health court, create a homeless court. California and other states have that. California recently, I think it was last year, the year before, Senate Bill 1045, which stated that persons that had a number of episodes where they clearly were demonstrating some of this disabilities and capacity, the state became their conservator. So summarizing those accommodations again, we have an enhanced peer support network, more assertive community treatment, more evidence-based psychopharmacology, like medication-assisted treatment, long-acting injectables, more evidence-based psychotherapies, and that summary, there it is, the thing everybody's been waiting for. Understanding and responding to this will require that we understand how persons with severe substance use mental health disorders have this hidden disability. And the stakeholders involved, those of us that are passionate about it, need to communicate this to every other stakeholder and point out the importance of providing accommodations in some of the creative ways and more creative ways than I've mentioned here today. So that's it from me. I don't know if anybody's still here. If you have questions, I don't know how they come across.
Hi, Mike. Yes, thank you so much. That was very good. We actually do have over 50 people still on. So we're going to open it up and have people allowed to ask questions on their own. So we have about 8 minutes left before the session ends. So we can go ahead if anyone has questions. We're opening it up for anyone to answer that's still in our session, which is about 52 of you still. So thank you again.
Sure. Well, people, if they have questions, is it going to be in chat or is it going to be?
They can unmute themselves and ask the questions. You just have to click. If you have any questions, just click unmute on your end. for attendees. Thank you. Any questions?
I'm scanning out there in the audience. I see most people sleeping. You, right there, wake up. Oh, yeah, that guy's eating his lunch. I see what's going on. Well, I totally appreciate the opportunity to be able to express some of the work and thinking that I've been doing about this complicated problem. And I appreciate all the other folks that share this passion that I have to help folks. And I wish I could see who all was here and I'd go out and talk story with some of you. But fortunately, I'm stuck here at the hospital. So I guess if there's no questions,
There might be, I see some people unmuting themselves. And Mike, I just want to say on behalf of the Awareness Committee, we are so thankful for you taking your time today. Thank you so much from Kona.
very well.
Maybe some people are shy, you know, sometimes that happens. Is there an email or something that we could share in the chat? Is it, they can email you directly if they have?
Yeah.
Okay.
Put it in here. Okay, so I'm putting in my email and my PayPal account. You can feel free to make a contribution to the Help Me Buy Lunch Today account. No, I'm just kidding. Okay, there it is.
Okay. Okay, so if there's no questions, then we could end our session. Again, thank you everybody for joining us. This year's
Hi.
Oh, we do have
Sorry.
questions. I'm sorry. Yeah.
Yeah, go ahead.
Okay.
Go ahead, Kayla.
Oh, okay. No, I just was gonna just say another thing.
Oh, somebody says there are a few questions, but when they unmute, it doesn't send anything. Okay, here's a question. Are there resources for helping to tell when someone is at the point they cannot make informed decisions? Can you talk a little more about the DOH recommendations for merging? Resources for helping someone when they're at the point they cannot make informed decisions. I would say at this point, you would probably best get involved with the family court and ask them about doing some kind of a capacity kind of evaluation. You can look into the assisted community treatment application that's available online. As I mentioned, IHS has Connie Mitchell there, the director of IHS, is a great resource for learning more about ACT and pointing you in the right direction. And those are probably the best avenues we have right now. Down the road, my dream is that our Office of Public Guardian would expand and take on more the role of providing the guardianship, the conservatorship for folks that are determined to be struggling with this and help them to make medical decisions, to help them make treatment decisions. The DOH recommendations for merging, I think one of my slides talked about an idea of cooperating more between the different divisions like the Alcohol and Drug Abuse Division and Adult Mental Health Division and Child and Adolescent Mental Health Division and even Developmental Disabilities Division. And I'm lucky enough right now to be also doing some work for a healthcare organization that is attempting to try to bring those folks around the same table, because it's these high impact persons that are really having the highest impact on the system in terms of cost, in terms of burden, and they are suffering the most. So this is where we need to get creative on solutions for that population. For the other folks that are able to engage in housing when it's offered, the efforts that are already going on are wonderful. And there's some great champions out there that we're seeing in the news that are, creating, mini houses and all kinds of great treatment approaches for those coming out of incarceration. So there's wonderful champions out there, and I, send my thanks to all of you. But for this particular population that I'm passionate about, we need to have more coordination, cooperation, and we're just beginning. I'm just looking through the list of who's here, see if I can pick on anybody, but I don't see anybody that I know.
Okay, so thank you so much. It's 1 more minute to 12:30, and then you left your email, so people will contact you directly if they have any questions. Thank you again, everybody, and have a beautiful weekend.
All right.
Aloha, aloha, everybody.